All right, good afternoon, everyone, and welcome to the section on pediatrics. Thank you for the committee for throwing this in. I'm a pediatric perfusionist, and I was really looking forward to this session. And one of the goals that the committee had in devising the symposium this year was having it be an international event. And I think this session really exemplifies that. We have a speaker, a perfusionist speaker from the United States in this session, a perfusionist speaker from the UK, and a physician that trained and worked in the UK and the United States. So I think it brings everything together really well. Our first speaker is Nigel Cross, who was the former chief perfusionist at Great Ormond Street Hospital, and he was kind enough to answer many of my emails years ago when I was a young perfusionist, and I had the pleasure of visiting his program just several years ago with Richard and Alex Robertson, and they were gracious hosts. And today he is going to be speaking to us about heparin-induced thrombocytopenia in patients undergoing heart transplant. So please welcome Nigel Cross.
I always feel such a fraud standing up here. There have been such beautiful presentations today, and I'm thinking I'm just a country boy and I don't really know very much. First of all, thank you to Sanibel for getting me here. I thought when I retired that I'd never be doing this sort of thing again, but here I am. Richard very kindly described me as emeritus, and that's never been associated with my name before, and I wasn't entirely sure what it meant, so I looked it up, and apparently I'm unemployed, which is great. So those are my, these are my disclosures. My acknowledgements, as always, I'm standing on the shoulders of giants. And I want, don't be shy, come together. I want people to be really honest and say how many truly understand that diagram. Because if I look at it for long enough, it actually starts to change. And it blends into it, and then you know, the letters change and the words change. To me, as I say, I'm a humble perfusionist. Blood has two states, and it's that or it isn't. So it's lumpy or it isn't lumpy. That's the question. Lumpy blood is really difficult to pump around. I don't know if you ever tried to do it, but it is. Thrombocytopenia, it's an abnormally low platelet count. It's inherited or it's acquired. Our normal platelet range is 150 to 450. Count below 50,000 requiring emergency treatment can be defined as thrombocytopenia, and the symptoms occur in about 40% of our patients. I suspect it's probably underdiagnosed as well, I'm not sure. Heparin-induced thrombocytopenia is a fall in platelet count with a hypercoagulable state on exposure to any amount of heparin. Two types, type 1, type 2. Type 2 immune antibody mediated reaction appears 5 to 14 days after exposure to heparin. As the antibodies form, patients develop a hypercoagulable state, which is a really difficult word to say, and with a 50% chance of embolic complications and up to a 30% mortality rate. So, causes unknown. Occurs in 0.1 to 0.5% of the population, higher risk in patients exposed to heparin post-surgery. There's a fair amount of, there's a review of incidence diagnosis in special populations. It's all a bit vague. Patients over 50 are more likely to be diagnosed with it. You are either, if you're female, you either are more likely to get it or you aren't, depending on which data you look at. We get platelet factor 4, PF4, normally stored in the alpha granules of platelets, released on activation. It's positively charged, and heparin is negative charged. Guess what happens? Binding occurs, forming a neoantigen recognized by IgG antibodies, and this leads to platelet aggregation. Aggregation. There's a new word. Try that one. Thrombin and more PF4 released. You just get into a vicious cycle. Platelet counts fall. Macrophages consume IgG anti-coated platelets. Stopping the heparin will stop production of activated platelets. The prothrombotic state can persist for up to 30 days. HIT antibodies are transient, typically undetectable after 100 days. So if we're going to manage our patients on bypass and they have HIT, we have to say goodbye to this old friend, heparin. They don't get on, and we have to get used to a new friend who's going to be called bivalirudin. Strange stuff. It's a direct inhibitor of thrombin, synthesized cogene of pyridine. It binds to both the catalytic and anion binding sites on thrombin. It doesn't bind to PF4, so you don't get any reactivity with the HIT antibodies. And then you see, you can put this diagram back up, and now we all know what it means. It's still moving around to me. And it's one of those convenient diagrams, isn't it? If you want to explain something, just put something in there and talk about it with enough confidence, and everyone will believe you. But that's the art of being a perfusionist, it always has been. The medicinal leech, Hiridus medicularis, medicinals. How many here? And I know there'll be one. Blackadder. Course of leeches. Yes. Some people will get that, many won't. It's indicated for acute MI, PCI, and heparin-induced thrombocytopenia. On that top line, I've had 2 of those, but I haven't had the one on the right. I also wasn't given bivalirudin. I had the snake venom side of it rather than the leech venom. The therapeutic dose for PCI, 0.75 milligrams per kilogram, followed by an infusion. There's no reversal agent. It's got a really short half-life. So time is your friend, and it is monitored, or can be monitored by standard kaolin activated ACT, so it's not too difficult to measure. We kind of looked at this narrative review of all the things that can happen using it. Is there a magnification? There is, because it's a bit small. But if we go to here and look at this column, you'll see lots of references to multiple pre-bypass boluses, 5 boluses, clot noted in venous reservoir, multiple boluses throughout bypass. It's okay, but it's a bit unstable. Our patient, 14-year-old female, 13 years old on admission, 49 kilos, 158, previously very fit and well, history of chest pain when on holiday, admitted to local hospital, central cyanosis, right bundle branch block, and T-wave inversion. She was referred to GOS on the 21st of the 8th, 2023. She had a fairly long and complicated admission. Forgive me, this is going to sound a bit like just reading a long list, but it is a long list. Had an echo on admission, widely dilated LV-RV, moderately impaired functions, calculated ejection fraction 30%, slightly better than mine, but not much. Echogenic mass in the RV apex, which was organized clot. Diagnosis of dilated cardiomyopathy secondary to myocarditis. She remained relatively stable, but as usual, there's a sort of progressive deterioration. By day 6, she was on increasing doses of adrenaline and noradrenaline, increasing desaturations down to 90 when she was asleep, just generally getting worse and worse and worse. We made a decision to intubate her with ECMO backup, which is a pretty standard practice. GOS is probably standard for most institutions. She got better, but the lactate still remained high. She then started to spike fevers. Platelets started to fall. A diagnosis of HIT was made with the PF4 induced antibody test. and then she just continued to deteriorate. Decision for ECMO support was made, anticoagulation strategy to continue with bivalirudin, successfully placed on ECMO. Nothing unusual about that, and she ended up with a 6-day run of ECMO. Clot had a high circuit load. She was well enough possibly to try coming off ECMO, and that was the decision that was made. So she was decannulated without incident. Day 22, she's then listed for transplant following a JCC. Extubated successfully on high flow nasal, so she sort of seems to be doing pretty well. 14th birthday, day 33. Made and decorated her own cake, which is always like one of those little moments, like your little moments. She was then, the decision was made to put her on an LVAD support. We cheat a little bit. We assume that a child of that age isn't going to be on an LVAD for very long because the donor pool will be quite big for someone of that weight. But we can't guarantee that, so we cheat by putting Berlin heart cannulas in, which is the apical and the aortic cannula, but we connect them to a simple central mag pump, which is a little cheaper, but not obviously long term. Greg, thank you very much. You had long conversations, I believe, with Alex, because you lent us this. Again, I need to magnify this. You'd done all the work, came up with what was really needed, broke it down into perfusion, anesthesiology, and surgery. Having done been a perfusionist for 46 years, and I do 2 HIT patients in my last year. I don't know, don't get it. None of those points are irrelevant. There's nothing that isn't there that doesn't need to be there, if you see what I mean. The one that I really like is under surgery, where it says pump suckers will not be turned on until bypass is initiated. Our poor surgeons, that's the only chance they have to dictate what we as perfusionists do. Suckers on, please. Nope. What do you mean, no? It's a joy to watch. The power. Lord Veterinary would say, si non confectus, non reficiat. If it ain't broke, don't fix it. So we used Boston's protocols to do it. 2 perfusionists for the case, not emphasis 1. It is going to get busy. You will be there all the time. Citrate for cell save, we didn't actually use it. No calcium in the prime. Flush out your CDI because it's heparin bonded. Don't clamp and divide the blood prime to sash until the ACT is 400. Suckers stay off until bypass is established. Keep the level low in the reservoir. You don't want areas of stagnation. That's probably the best word for it. And the more blood you've got in your reservoir, the less, whatever the word is, there will be areas where the blood flow is slower and possibly stagnant. Keep the suckers flushed. So make sure that there's a big bowl of saline, because you again get stagnant blood in the suckers, and that will it will clot. So flush them through as often as you can, which means there's got to be a lot of communication, because your surgeons will forget to do it because they're busy. So you just get the assistant to do it, or your scrub nurse to do it. Once you're off bypass, keep the aortic cannula flushed, or just remove it if you think the patient's stable enough. The circuit, standard primes. I had nothing to do with this. This was done by the clever perfusionist in the department, which was Alex. So you can be pretty sure that it was all. I only worked 2 days a week when this came along. Normal temperature bypass, because this was just for the insertion of the LVAD. We stay warm. There's no cardioplegia. 103 minutes of bypass time. It was tricky getting a suitable ACT of greater than 450, and it involved multiple boluses from the anesthesiologists and several multiple boluses on bypass. It took a while to get everything to a point where we could. very straightforward bypass run by Valerian, stopped at 10 minutes before the bypass ended. Lines were reconnected and circulated. So you disconnect the lines from the cannulas, plug them back together again, keep your pump circulating. I'll show you what happens if you don't do that. Chest was closed with an ACT 390. Back to CICU, good condition, 2.2 litres per minute. Patients now listed for transplant. Now we have, I'm sure everybody has the transplant theory, in that if you do something that's expensive and complicated, 2 days later a heart will turn up. Because you invoke the transplant theory. Sure enough, 2 days later we have an offer. This time it's me, I'm on call for this one. Whoopee! This is typical, it's also an overnight transplant. So it was myself and Richard Crook running it with me. So it was good fun. It was a good fun team as well, which you need. You need a team that you can communicate with. Sometimes humor is needed at that time of the day. Patient, because had been CICU'd, had a much lower hemoglobin, so we had to add a little bit of blood to the prime, and we washed it off with 1,300 mils of plasma, rather, just to, well, prevent exfiltration, just because it's something we can do. It feels good. We had the benefit of practice, and because there was a transplant, we had time limitations. We didn't have time to wait, so we just gave a huge, massive bolus of biliverdin, 450, and then additional 50 milligrams to achieve the ACTs we needed, 200 milligrams on bypass protocols as for number one, but we flushed the donor heart with crystalloid cardioplegia to remove any possible remains of heparin. Pretty standard transplant called 34, 80 minutes. Cold ischemic time for the organ, 235 minutes. CICU with stented open chest, delayed chest closed 3 days later, no post-op complications, discharged to home on 27th of the 10th, 23. So a nice, good all-round result, a learning curve for everybody. I get to do an HIT patient for the first time in my life. Whoopee! Was it uncomplicated? Halfway through the case, I think they just manipulated the heart a bit, but we were running probably levels which were too high in the reservoir, but the level dropped. Oh, all right, it's the next slide. Doesn't matter. Where are we going here? Oh yeah, okay. So there were 2 bypass runs within the space of 2 days. They were reasonably short, they're uncomplicated, and our conclusions were, yes, you do need 2 perfusions. It's hard work, thank you. Bivalent routing works, but it likes to take its time. It's a little bit unpredictable, it's a bit mysterious, but it works. 2 ACT machines help. Personally, forget the expense. Build another circuit, prime it, put it next to you in theatre, because you can't, we realized afterwards, change individual components of that circuit, because you'd have to stop the circuit. If you stop the circuit, it closes. And talk to each other. Was it uncomplicated? Yeah, halfway through the case, the level in the reservoir dropped. And this appeared. It didn't appear because, again, I've got another slide in the way. Keep forgetting that. Clot noted in venous reservoir with an ACT of 514. Oh, so that appeared in our reservoir. So Richard and I, it's about 4 o'clock in the morning, Richard and I look at each other and we go, and he goes. So eventually the level in the reservoir went up again. And I'm a firm believer, if you can't see it, it's not there. So we left it. Whether that's the right thing to do or not, I don't know. But changing it would have been a nightmare. It really would, because we hadn't got a circuit belt. That's the reference to getting this whole circuit belt. And that is what happens if, because it was me running it and I'm a bit not as clever as Alex, and I forgot to do the recirculation bit, that happens very quickly after coming off bypass. The patient was safe, we were fine. But you end up with just jelly in your reservoir. I retired. Do you notice, look, this in the film world, this is called continuity. I retired. 4 days later, can you help out tonight? Like 4 days retirement. We've had a busy weekend. We're all a bit tired. We're all a bit frightened. Yeah, whatever. We've just accepted a heart patient. DCM should be straightforward, but we need backup because the patient is recipient on ECMO and we'll just need help and has hit. Thanks. So that happened. I'm retired. Yeah, right. Previously fit and well, 11-year-old. It's always so sad, isn't it? Mark has his patients that fit and well and then really not fit and well. Was transferred to us from Brompton for transplant assessment. Therapeutic heparin, hit diagnosis made on the 29th of the 5th, urgently listed on ECMO established. That doesn't make sense. Anyway, an offer was made 6 days later, I guess. So it would be 29th of the 6th. I don't know. It's time. Whatever. Wasn't with us for very long. On ECMO, had an offer. Because the patient was already on ECMO, it was really quite easy to get our ECMO specialist to just ramp up the bivalirudin until we got to the point where it was acceptable. They were very good about that because that's sort of slightly outside their protocols to run ECMO with ACTs 400. We transferred to bypass using the ECMO cannula with an additional IVC, essentially, again, a very straightforward bypass. And guess what we found? A clot. This is my favorite oxygenator in the whole world, the RX-15. I'm not advertising it, but I've used a lot of them. It sort of got me out of trouble a couple of times and things. But maybe there is, because it's almost exactly at the same level, maybe there's a little area of lowish or static flow on that waterfall. Don't know. It's not a criticism because it's a very unique situation. However, I've waffled on for long enough. Thank you so much.
Thank you very much for that talk. Well, first I'd like to say congratulations on your retirement.
Thank you very much.
And you're quite a guy for coming in. You had it up on the slide, but I'm not sure how much information they actually gave you before you showed up for the HIT case. When you decided to come in 4 days into retirement, did they just tell you, can you come help us out, or did they actually tell you about all the ECMO and the HIT? And
well, lots of factors. I really like doing transplants. I really like being considered a bit of an expert, even though I've only done one, because that's an ego thing. Yeah, it wasn't a difficult decision to come back and work.
Are there any questions from the audience?
Please not coagulation, please.
It's no, it's not a coagulation question. It's more of a dosing question. I mean, I noticed, your initial dosing was 0.75 milligrams per kilo, infused at 1.75. Boston's is 1 mg per kilo, infused at 2.5 mgs per. But the numbers that you had up there were 450, 500 pre, and then another, 400 or 500 on pump. I'm just wondering if these dosing calculations, we have it too, they're very low, it seems like, and we end up giving a ton more.
Yeah.
And is there going to be accurate dosing? I mean, do patients, you've had probably more experience with this, Greg, as far as the HIT stuff, but do most patients require this much? I mean,
it's pretty
grams of
I've done 2. It's now 3, isn't it? Because we've done another one. It's like,
what I think is very interesting about HIT is it doesn't matter if you've done 1, 2, or 10. Every patient is so different in this realm. And I think a couple important points that Nigel made was, number one, running ACTs and he recommended having a second ACT machine. And I think we should appreciate that the Hemocron Signature Elite is an accelerated test. It actually gets your result typically before however many seconds it's going to predict, right? So it's actually a Kalin equivalent ACT. So I think that's great when you need data really fast. So I think that's important. The other important thing that I appreciate Nigel sharing with us is his appreciation of the FX series or RX series devices, because you can see the cardiotomy filter separate from your venous filter.
Yeah.
And I think that's critical when you're working on the margins in cases like this. If you have it all cascading together, you can't see if your cardiotomy is clotting versus your venous, or it's very difficult to figure that out. So I think choice of device is also very important.
And to follow up real quick, just are there any other tests with all the new anticoagulation, TEG success, the ROTEMs, things like that? They don't really measure ACT, but are there any other tests out there that could possibly help us better than an ACT with bivalve? Or could we do a plasmapheresis type of thing, just add a bunch of plasma to the prime, and would that help with the hit or not? I don't know if there's some other way to treat this.
Just a dilution. I don't know.
Dilutional.
I know there is another way to treat this. At Stanford, we use Flolan, and it's a prostacyclin analog, and it goes through the vent circuit. And so we don't change our heparin protocol or practice. We just use the Flolan, and we've done for HIT patients, and yes. And then we've done at least 4 or 5 of these with no adverse outcomes. It's a game changer. We should write it up.
I'm also officially no longer a perfusionist, so I'm never going to find out. I didn't get my numbers, so I'm no longer accredited.
But actually, I'm going to make a comment on this, is the fact that it's lovely that, we're on the street, we use the Boston protocol, and now we've just learned there's a way from Stanford. And actually, it's coming having these conversations that we find this, and somebody else may come around and say, well, actually, we've got this way. But at least we've got a chance of knowing.
Just by show of hands, how many perfusionists here have been involved in an HI2 patient? Oh, I asked the same question in New Zealand. It was like a few, not many.
I have a couple questions online that are similar, so I'm going to paraphrase them into one. But do you change your perioperative, postoperative protocols if these patients are prothrombotic, for like in the postoperative period, if they have low cardiac output or any issues like that? Do you anticoagulate them further so they don't have a thrombotic event?
That's a CICU question. I genuinely wouldn't know, and I probably should do, but we just kick them out the door and let the intensivists worry about them. Shouldn't say that. But I don't know. I mean, yeah. Do we know? Do you know?
I think it would depend on the level of, thrombosis,
Yeah.
if they're experiencing any thrombosis. All right. Thank you very much. Have a round of applause for